Good morning. My name is Erica, and I will be your conference operator today. At this time, I would like to welcome everyone to the KOL conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. You may begin your conference call.
Thank you, operator, and good morning, everyone. My name is Gina Wan. I'm a SMID-cap biotech analyst at the Barclays. On the call with me also have my colleague, Jeff Meaching, our U.S. pharma analyst. Jeff, are you on the line?
I am, yeah. Thanks, Gina.
Okay. Well, thank you, everyone, for joining our call to discuss about ATTR market landscape after patisiran approval and the tafamidis phase 3 data earlier today at the ESC. Please hold your questions until the end, and as always, you can send us emails your questions if you prefer anonymously. Today, we are pleased to have with us Dr. Van Selby, Assistant Professor in the Division of Cardiology at the UC San Francisco. Dr. Selby's clinical interests include advanced heart failure and pulmonary hypertension, particularly with a focus on patients with heart failure due to cardiac amyloidosis. Dr. Selby has been involved in multiple clinical trials in ATTR. Dr. Selby, we had a call prior to patisiran approval and the tafamidis data, and you shared with us your thoughts on market dynamics and how you would use different drugs. And today we have both patisiran approval with label as what we discussed in our last call as scenario 3, hereditary ATTR with polyneuropathy without cardio data included in the label. And tafamidis phase 3 data also have been reported this morning with 30% reduction in both all-cause mortality and hospitalization. We would like to revisit the topics we discussed previously and get your latest thoughts on how you would use these drugs in different patient populations and how the trial design would be like for the second-generation drugs. Since, tafamidis data is still very fresh in everyone's memory, and maybe let's start with your thoughts on tafamidis data.
Okay, great. Thank you, and good morning, everyone. I would say, to put it briefly, that the tafamidis data came out on the better end of the range I was expecting. I think we all knew that it met its primary endpoint based on the press release released several months ago. But I thought it was nice to see that it met on both mortality and hospitalizations. And then I thought the magnitude of the benefit was quite impressive with a 30% reduction. I think when we talked previously, I said I'd take a 10 to 15% reduction in these outcomes just because we have no other treatment for these patients. And so I got what I wanted and then some. So I was happy with that. I think that on my personal read of the data, it looks like the benefit was relatively stable across the different groups studied. There were some differences we can go into, but I thought that it was a pretty clear beneficial outcome for all patients studied.
Okay, great. So maybe we can go into specific data point. So I think one is the placebo versus the drug arm. I think the last time we also talked, you also comment the placebo assumption could be higher, and here actually they had a 42.9% survival rate, and then the drug arm actually was a 29.5, like close to 30%. How do you think about these rates?
So I think the 40% was maybe even slightly higher than I would have expected. I think as we previously discussed, the anticipated 25% may have been a bit of an underestimate, but over 40% at 30 months is a pretty poor survival. I think that the improvement shown by tafamidis is excellent, but it also still leaves a fair amount of room for improvement. 30% survival. It seems it may be possible with either additional medications or other medications to even improve on that.
Okay. And then, second question is regarding the survival curve separation. I'm pretty sure you also saw the survival curve. They said they started to separate at 18 months. And how do you see the data here regarding the reason why 18 months, and then it seems like separation goes pretty rapidly after 18 months. And if you can give a little bit more color on this curve.
Yeah, so I think it's not too surprising that it took a little while to start to see a difference, and I think that's for two reasons. One, as you know, tafamidis is a stabilizer, so it doesn't take out the amyloid per se that's already deposited in organs. It just stops ongoing deposition. So it might take a little while for the body to adapt and start to see benefit from it. You may also see some, the body's innate recovery processes clearing out the amyloid or improving the cardiac function over time, but that is going to take a while. So I thought it'd take at least a year to see a benefit, and it looks like it's really closer to 18 months where you start to see. The other reason I think it took so long is because they looked at a very hard endpoint of primarily driven by cardiovascular mortality, which again, I think if you're just shutting down ongoing amyloid deposition, it makes sense to me that it's going to take a while before you actually start to see such a clinically meaningful benefit. They may have been able to look at other markers earlier on and see improvements. And I think they actually did report improvements in things like quality of life and 6-minute walk at 6 months, if I'm remembering correctly. But to see such a hard endpoint like mortality, it can take a little longer.
Mm-hmm. So maybe, since you mentioned the 6 minutes walk test, I believe they started to see around 6 months show the separation. If you can help us understand, the dynamic here, and also I think the other secondary endpoint for the Kansas City
cardiomyopathy questionnaire. Yeah. So I think they did show pretty clear statistically significant benefit in both. I was actually a little surprised to see that there was a benefit quite this quickly, just because again, you're just stopping the deposition of new amyloid in the heart. So I thought it would take a little longer to see really clinically meaningful benefits, but they did clearly show significant improvements at 6 months in both. And the fact that they got it in both outcomes really solidifies in my mind that it probably is a real benefit, not just a problem of too many secondary endpoints. So it looks like, although it may take a little longer to really get the meaningful outcomes we love so much, like mortality and hospitalization, you can at least start to see some benefit early on.
Mm-hmm.
Gina, I just have a quick question on this one. If the patients, for example, had more severe or were let's say sicker patients overall, had more deposition, would you expect the separation to be closer to, say, 12 months? And then the second part of that, the corollary, would be how representative do you feel like this population is of either your practice or the real world, so to speak?
So let me answer that second part first. So I'm pulling up their table 1, but from what I remember, it was pretty well represented. I would say my in terms of age, their mean age was around 75. That's my mean age of my current patients might be slightly older than that, just because there's so many more wild types coming into play these days. But still in their 70s. So I think it's a relatively good representation of my patients. Also, over 90% male in the tafamidis group. That is very much in keeping with my patient population. Amongst the mutants, the other thing I like to see is that they have the mutations that I'm seeing. So they had a lot of V122Is. That's the exact mutation that I'd say makes up about 80% of my mutant TTR population. So all those are really consistent with my patient population. And as I've complained with some of the other, more neuropathy-based trials, they didn't study my exact patient population. I think this trial did a lot better. I would say mine is probably a little more evenly split between class 2 and class 3, whereas they were more, I think 60, it looks like 60% class 2 and 30% class 3. So maybe I have slightly more class 3s in this, but overall a very good representation of my practice. And then the other question of would it have taken a little longer if they were a sicker population? Yes, perhaps. They as heart failure progresses, you start to get secondary neurohormonal activation, and also just weakening of the body's muscles, and just other processes beyond just amyloid deposition in the heart. So one could argue that first you shut down ongoing amyloid production, then maybe the body clears some amyloid out, and then you start to see things like reductions in this neurohormonal activation or frailty or whatever it is that's kind of piled on top of just the cardiomyopathy that's making a class 3 or class 4 patient so debilitated. So
okay.
yes, it seems like it could. Go ahead.
There's nothing unusual about it separating at 12 months versus most people were expecting. Sorry, separating at 18 months, whereas most people were thinking 12. Just so
now you're talking about the survival and hospitalization.
Yeah.
So I think anywhere from 12 to 18